Thank you, Dirk, for the introduction. This is a talk that's going to reinforce some of the same points that Professor Zeller just discussed, and it's one that I think we're hearing more and more about, this issue of combination therapy, vessel prep, and that sort of thing. I think the good thing in the last few years, we have a number of devices and some good data to support use of these devices, but many of these devices were investigated in trials that were limited to lesions that were not particularly the ones that we see in day-to-day practice. So it makes sense that as we apply it to our real-world patients, we're needing to use these devices in combination to get the best results, and that's to some degree what this talk is about. These are my disclosures. So we all know the challenges of successful intervention in the femoral popliteal circulation. You can break these down into two main issues: biologic factors and mechanical factors. Biologic factors being the patient's tendency to develop intimal hyperplasia or restenosis, which varies from patient to patient, and mechanical factors, which are affected by lesion length, but it certainly include plaque burden and heavy degrees of calcification being one of the bigger problems with these different mechanical forces that continue to interact in the SFA after successful revascularization. One of the more exciting things that we have now to treat the SFA are drug-coated balloons. There are two that are available as a result of the Levant trial and the Impact SFA trial, with another one probably coming to market soon. And these devices have certainly been shown to be helpful. In both Levant and Impact SFA, we've seen improvement in primary patency and in between the drug-coated balloon patients versus the plain balloon angioplasty patients. And in the case of Impact, this is true and sustained even out to 3 years. So we now have something that is demonstrably better than PTA that does not involve leaving a permanent implant. And I think this is pretty advantageous to have this in our arsenal. That said, there are certain limitations of these devices. Both the Levant and Impact SFA reflected lesions that were fairly short in nature, again, not the things we deal with in day-to-day practice. And when you look at these two studies, as well as a host of other studies looking at DCBs and other femoral popliteal interventions, we see that as our lesion length increases in length, we have a diminishment of that primary patency and worse outcomes over time. And so this was true in both of these trials as well as other trials. So in terms of my practice, at least, I was somewhat cautious in rolling out the use of DCBs. I tried to keep these initially to those patients that were similar to those in the randomized trials, which is a select group. But with the Impact Global Registry, as we've just heard about, we have good reason to expand the use of these devices to more and more patients. In the long lesion cohort and the CTO cohort, imaging cohorts of the Global Registry, we have truly long lesions of 22, 26 centimeters. So these are not our standard 5 centimeter lesions of the IDE trials. These are truly long lesions. And if you look at the primary patency, again, you see really what I'd call phenomenal primary patency at 1 year for such long lesions. And this is somewhat unheard of compared to all of other IDE trials and other trials that have looked at femoral popliteal interventions. The problem with this, of course, is that in both of these trials, in this registry, we have a very high stent rate, so upwards of 40 to 50% stent rate, bailout stent rate intraoperatively in order to get these high patency rates. And so this continues to become a problem in terms of how we're going to treat this vessel without having to leave a permanent implant. We've all seen this slide before. This is Dr. Finelli's slide that discusses the role of calcium in terms of primary patency and late lumen loss. And there's some suspicion that the paclitaxel that must elute into the vessel wall is inhibited by the calcium burden and the plaque burden. And especially as we get to circumferential calcification, we see a really dramatic effect on primary patency and late lumen loss down the road. And so calcium, no doubt, is one of the factors that interferes with our good results with interventions. And so while DCBs are effective tools, results are likely diminished in long lesions, long occlusions, and heavy arterial calcification. And what about the use of adjunctive stenting in complex disease? And so one argument is just to use stents in combination with this residual plaque burden, and that may be a reasonable strategy if you look at the Global Impact or the Impact Global Registry. But I will say, and I will point out, that every US IDE trial has shown an improvement in primary patency with stents over PTA, but in every one of these trials we see the same trend, which is decreased primary patency with long lesion length. And I think most laser cut nitinol stents are subject to these problems. One exception to this may be the Superest stent. This is a very crush-resistant stent that is very versatile in terms of its ability to withstand torsion and cross knee joints and deal with this heavy calcification. So this is one perhaps exception to the rule that calcification and lesion length is the death knell of some of our femoral popliteal interventions. But this device has its drawbacks as well. Deployment accuracy and those sort of issues are something we're still sort of working to overcome. So I would say that the outcomes with stents and long calcified lesions appear improved with some of these next generation scaffolds, but overall these results remain compromised in the presence of heavy disease burden and justify the trend toward movement away from the use of a full metal jacket and more selective spot stenting when required. So the question is there any other strategy we can use to reduce the need for a permanent implant but still get some of these excellent results that DCBs try to promise? Atherectomy is the obvious choice for this. Atherectomy, as we saw from the case that is ongoing now with Prakash, atherectomy has the ability to change the vessel in some way to change its compliance or to remove some of the plaque burden. And these devices all differ, certainly. Some are better than others, I would say. Some are probably, you could argue, just different applications and different types of lesions. But these do have the ability to modify plaque and change the vessel itself. When discussing which device, I won't get into which device is better than others, but I would say that the device that we want for this combination therapy between atherectomy and DCB is one that has the ability to remove calcified plaque, so decrease some of this plaque burden and specifically deal with calcium because it's such a impediment to, potentially an impediment to drug diffusion. Ideally, we want to generate something use a device that generates significant luminal gain and has a favorable complication profile. And of these, excisional atherectomy does have core lab adjudicated data in a large data set that shows that you can have what we call stent-like results without the use of a permanent implant. And so excisional atherectomy seems to be well paired or well suited for this combination therapy. The first study to really, there's been 3 studies that begin to explore this topic. There's one randomized trial called Definitive AR, and this is really just a 100-patient pilot study that randomized patients between atherectomy plus DCB to DCB alone. This was done primarily in claudicants up to patients with Rutherford IV disease. And the lesions were, again, not particularly long, 11.2 centimeters, so they're not short, but I wouldn't say there are longer lesions, as well as a registry arm, about 20 patients that had severe calcification, the rest being mostly moderate calcification. And the thing that I'd point out to you here is again, at 12 months, we had really, at the time this was done, a phenomenal primary patency of 91%. In lesions greater than 10 centimeters at a year. And so this was pretty good. This was before the DCB trials, and this at the time was among the best patency that we've seen with these type of lesions. There's been a couple of other studies that looked at combination therapy. One study looking at combination therapy in popliteal lesions and another one in femoral popliteal lesions that were heavily calcified. And again, we see a similar trend of about 90% primary patency a year. So these 2 smaller studies support this pilot study of Definitive AR to suggest that there is something to this data. And I should point out that overall this was essentially a negative trial in the sense that if you looked at all patients, those treated with atherectomy and DCB had no statistically improved benefit over those patients treated with DCB alone. But when we look at the certain subsets, those patients with longer lesions greater than 10 centimeters, and those patients with severe calcification, again, we didn't reach statistical significance due largely to the small sample size here, but we saw very clear trends of improved primary patency in those patients treated with this combination therapy. And so this was very encouraging and sort of paved the way to further explore this issue. And this is what we're doing with the reality trial, which is a trial that's been ongoing now for just over a year, or just under a year, I should say. And this is basically a multi-center international prospective single-arm registry where we're using a core lab adjudication of both IVUS imaging, duplex ultrasonography and angiography to really define these lesions, which are generally long lesions, lesion lengths up to 18 centimeters here in the U.S. and up to 25 centimeters in the 3 German sites, with occlusion lengths up to 10 centimeters, all of which are moderate to heavily calcified. And so these are truly calcified, truly long, complex lesions that we're hoping to sort of further explore the signals that we saw with the Definitive AR trial. So in conclusion, I would say that significant limitations do exist with the use of standard nitinol stents and DCBs in long lesions. The evolving concept of vessel preparation with atherectomy in combination with DCBs may prove to be the optimal therapy for complex femoral popliteal disease. And the reality study will further explore the trends seen in definitive AR to help better understand the results of this combination therapy. Thank you.